Hello, everyone. I'm Dr. Joseph. I'm one of the resident here in New York at NYU Langone Health. As you guys know, unfortunately, life has changed. Life is not the same. We're gonna come down to Jamaica to give it to you guys live, but this is the best that we've got at the moment. If you guys have any questions, any concern, you can always email me, and my email is jjoseph.jj27@gmail.com. Again, it's jjoseph.jj27@gmail.com if you have any further questions or just need clarifications. So today we're going to talk about dental trauma, specifically pediatric dental trauma, how to prevent, diagnose, evaluate, and treat them. And there's a link here to the guide to acute traumas, PDF. You can just copy and paste it. And the objective, we're gonna go through them as we are presenting. So where to start is, every time a parent comes in with trauma, they'll be anxious. So the biggest thing you can do is calm them down. And just knowing the prevalence of them. If it's a blunt trauma, you're going to get more soft tissue and surrounding structure damage versus high velocity trauma, which is luxation and fractures of teeth. If a child, breaking down by age, the prevalence of them, 0 to 5, as you can expect, they start walking and crawling. Falls are very common. Dog bites are common. Child abuse, extremely common. So when a parent comes in and says that with a bite and they say it's a dog that bit my child, you have to investigate, because I'll show you guys later. If it's a dog bite, it's going to tear flesh. If it's a human bite, it's going to compress, make like a U shape. And again, with falls as well, and other scars in the body. If it's in the knees, elbow, yes, they're crawling, they're playing. But if you see injuries in multiple areas with different healing, then you have to suspect child abuse. But then between 5 to 10, we start seeing more of play accident in sports as well. And then 10 to 15, definitely sports. So we're going to talk about things like mouth guards to help prevent. And then, total injuries, the most common would be falling from a bike, chair, and force of facial structures. We went over that. Trauma prevention, you just want to child-proof the house, helmets for sports, bicycle helmets, mouth guards, and for kids that are hyperactive, like ADHD, got to talk to parents about that as well. And dental facial abnormality, malocclusion, severe overjet, high risk for trauma as well here. Here, high risk for electricity, electrical burn. You want to child-proof the house so they don't fall down the stairs. And when a patient comes into your house, your office, at my house, recording this, that's why I said house. When the child comes into your office, you always want to always photograph the injury. Pictures are worth 1,000 words. And ask what happened, when it happens. That has implications in terms of the timing of the injury in avulsion. 60 minutes, within 60 minutes versus after 60 minutes. Any treatments that were done prior to this, let's say avulsion, did the parents put it back in the mouth or not? Like what happened? Did they seek help elsewhere? Where? It was inside the house or outside the house? Because you want to evaluate between dirty and clean. If it's a dirty one outside with dirt, all that stuff outside, you want to think about tetanus booster, antibiotics maybe. So you always want to ask if the immunization is up to date and how it occurs. And that also will help you sort out whether it's a true accident that happened versus um, child abuse. And this one, the importance of this is that before you treat teeth, mouth, you want to make sure that there are no signs of head injury, CNS involvement. If a kid, a simple question, loss of consciousness, were they dizzy? Did they vomit? Um, difficulties eating, numbness, anything that shows that there's it's a closed head injury and CNS involvement, medical emergency. Send them to the hospital if they came to your office, and if they went to the ED, let the emergency doc um, stabilize the patient medically first, and then come do the dentistry. And here is history examination. Just look. You have to look. Don't just zoom into the teeth. You have to look around. Medical history, because that has implications on, what type of teeth you're gonna reimplant. Reimplantation is contraindicated, permanent or primary. Primary teeth, you never reimplant a false teeth. But however, if it's reimplantation is, contraindicated if it's a primary tooth. If it's a permanent tooth, you do not reimplant if the child has an immunocompromised immune system. They can't fight infection. If they have severe and controlled diabetes, anything that, they won't be able to fight that infection that you're putting into the tooth that will result in more complications, then you do not want to reimplant at that time. And also looking where do you see laceration? Some of the common things you see: chin laceration, look at mandibular fracture, and stuff like that. And for us, cranial nerve function, that's very important as well to know. And you don't need to know every single cranial nerves, something that you've learned early on. Just a refresher, reading through them, it's good to know. And a rapid neurological test that you can do is looking at the extraoral muscles, such as, can they track your fingers left to right, or you shine a light reaction, then okay, my cranial nerve 3 is intact, the oculomotor is intact, know that. And also sensory, light touch to the face, and symmetry, can they smile, tongue, when they put it out, is it straight or is it deviating? All that, then that my cranial nerve 5, trigeminal, is intact. Facial nerve, facial expression, smiling, frowning, just checking all that. I have to fix here because here it's not cranial nerve 5. This will be 6, 7. Okay, and then this is my 5. I am sorry about that. Okay, so now we have it. Tetanus booster, inside versus outside wounds. Child abuse, this is very important for your practice, very important for your test as well. You want to recognize and report any child protective services if you suspect anything. Photograph the area. It's better than describing what you saw. Physical abuse, 30 to 65%. It's in the head and neck area, commonly in the lips, not because of the smiling, but forceful feeding, stuff like that. Some of the types, the injury does not match the given history. The child tells you something, the parents tells you something, and what you see clinically with your clinical judgment doesn't match. Then that's a phony. Multiple injuries in different healing stages. It's child abuse, sexual abuse. You see some signs of STDs. If you do the test and gonorrhea comes back, chlamydia, then it's pathognomic for sexual abuse. Bite marks, as I said, with animal bite marks, it tears flesh versus human bite marks that will compress flesh, as you can see right here. And neglect, it's very common type of abuse. Multiple caries is a type of abuse. You just have to investigate: is it because they don't have access to care, or they just neglecting the child? Malnutrition. Bullying is another type. And this fancy word, Munchausen syndrome by proxy, which parents will fabricate a illness of a child That is a type of child abuse. And then verbal abuse, which is difficult to identify. So very, very important um, in terms of you as a provider to prevent detrimental thing. Every time you suspect that the child is being abused, you tell the parents that you will report them to social services and make sure that the social services follows up. But your duty is to report and do report. And this is a child that the history they were given didn't match the finding, and they were reported to social services. And then you want to discuss to parents when they come what to expect. The teeth may change color. That's one of the things you want to tell them, will happen. And also tell them what are the sequelae to the permanent teeth. If a tooth change color doesn't mean you have to take it out. It just means that, there's some underlying things that's happening, but the only time you have to take them out, if it's primary, if there's an infection, swelling, pus, pain. Permanent, you start endo. Different type of endos we'll go over. And when the primary teeth gets injured, you want to tell the parents what's going to happen to the permanent, such as it may stop the development of the bud to enamel hyperplasia, hypocalcification, hypomineralization, enamel defect, root dilaceration. So if there's an injury with the primary teeth, you have to let them know that there may be you know, things that will happen to the permanent teeth. And then those are the different sequelae to dental trauma, pulp canal obliteration, inflammatory resorption, and replacement resorption. With pulp canal obliteration, worst prognosis if it's a laxation evolves immature teeth with open apex, then the pulp canal will obliterate. So you want to initiate endo immediately if there's a periapical lesion. And follow-up. Follow-up is very important in the case of traumas. Inflammatory resorption, internal and internal. Again, luxation injuries from inflamed PDL. And when that happens, you want to immediately extirpate the pulp and then copious irrigation with sodium hypochlorite and calcium hydroxide. And again, long-term follow-up. Replacement, resorption, and ankylosing. This is an irreversible process, unfortunately. Once it starts, you can't stop it. There have been studies that shows the recommendation is to soak, if the tooth is evolved tooth, you soak it with sodium fluoride to slow down the process of replacement, osseous replacement, soaking it with fluoride. And then just tell the parents the possibility of a complete resorption in 3 to 4 years. And then this is just the overall. I'm going to spend some time here, and then we'll fly through them as we go through it. So you want to identify what happens. Let's say you're looking at primary teeth. And if this is a primary tooth and you just have a crown fracture with no proper exposure, it's a baby, the 3, the 4, the 5, or the 2. No proper exposure, there's no, unless there's like sharp edges, you can quickly smooth it out if there's no sharp edges, and the child does not cooperate. You do not have to build it back up. Just leave it as is until it exfoliates. But if the patient is cooperative and the parents wants, aesthetic is concerned, you can build it back up. But usually, crown fracture, you leave it alone. And let's say if you have like a primary tooth with a severe laxation, it's very loose. It's a 3-year-old, and you're concerned about aspiration. Good time to take it out because you don't want them to aspirate that tooth. Okay, and then if it's just a little concussion right here, a little loose concussion, we see the P as a little widen. You don't do anything, as long as it's asymptomatic. There's no swelling. You just palliative treatment, soft diet, and you just tell them to take over-the-counter pain medications and active monitor and follow-ups. Okay, you understand? And if a primary tooth is evolved, you never reimplant the primary tooth. A lost primary tooth, never reimplant. But then let's go over to permanent tooth. Permanent teeth, if you have like a crown fracture, with a crown fracture with a permanent tooth, you you know you, you cover it up, you build it back up. If they have the piece of tooth, you cover it up, and that's going to help with the sensitivity and aesthetic as well. If it's depending on where the crown to root fracture is, uh, you know if you can restore it, you restore it. And something like if you have a root fracture, for instance, a root fracture, it's better prognosis if it's on the apical third, and worse prognosis if it's on the um, coronal third. So you're gonna splint for a longer period of time versus, let's say, if it was just a subluxation. With that, you don't have to splint for that long, 2 to 4 weeks. And when you split, you're gonna split um, two teeth to the distal and mesial of the teeth that you are interested in. And again, avulsion, we're going to talk about the timing within 60 minutes versus after 60 minutes. Okay, this was a big overview, and then we're going to go through them each one individually. Enamel fracture, as I said, you just, loss of enamel, you replace it. Enamel dental fracture, that you can see one of my patients, dental fracture. You just again, if they have the piece of tooth, you replace it, and if they don't, you build it back up with composite. Most of the common thing will be sensitivity, and then you follow up. You look at the apical, make sure that there is no abnormal endo testing or no abnormal apical lesions. Long-term follow-up. It's very important to tell the parents that you have to keep up with the appointment, because most of those patients will disappear and not making the appointment for various reasons. So you want to talk to the parents and look at what may be a rate limiting step of them showing up to your office. And then long-term follow-up, 6 months. And then with dental pulp fracture, pulp exposed and then sensitive to stimuli. If it's immature apex, you do pulp capping or partial sulfectopotomy. Sulfectopotomy we'll discuss later. Pretty much you're just removing 2 to 3 millimeter of the inflamed pulp, and then you are covering it up with a perfect seal, so there's no leakage into the pulp, and then let the apex, the root, continue forming until it's closed. Then you can do a more definitive treatment, if indicated, like a root canal. And then with the crown root fracture without pulp exposure, you just look at where the fracture is. You just have to decide whether to keep the fragment or remove the fragment, and doing endo versus surgical extrusion of the tooth or submerge for future implants. So you always want to keep that in mind as well, preparing the parents, mentally, so they can prepare financially for future implant if indicated. But unfortunately, if it's a severe apical extensive of fracture to a vertical fracture, adios amigos, fortunately. With pulp exposure, pretty much the same thing. Now you have to consider endo and see if the tooth is restorable. Okay. And root fracture, as I mentioned earlier, better prognosis if it's on the apical third, right here, apical third, and worse prognosis if it's on the coronal third. And root fracture on any test is the only one that's going to have a longer splint time, especially if it's more cervical, up to 6 months to weeks. Every other types of trauma usually is 2 to 4 weeks, and for this one it's longer, weeks. And then you just monitor the tooth. This is one of the cases. As you can see, it's more apical, and you splint again. That's what I was talking about with the splinting. You want to splint, the teeth in question. So in this case, we're interested in these two, and then you want to do 2 teeth, distal and mesial, to those teeth in question. So if it was this one, I'm going to do 1, 2 teeth past that, and then this one, 1, 2 teeth past that. But let's say if it was only these tooth in question, my splinting will go 1, 2, 1, 2. Okay. And again, you know, they came in, the patient had recurrent gingival swelling, and they started endo. As soon as you have swelling, you started endo, and that will help with the healing process. Okay, and let's say if it's a severely crown to root fracture, and one of the things that you may have to do is put a post. So you tell the parents about the possibility that we'll need a post for the buildup for the crown, you know, until they stop growing for a more permanent aesthetic PFN. And again, here, as you can see, a root fracture here. It looks pretty bad now, but you can see, you know, some people may say extract. It's a big dilemma, but you want to do the least conservative treatment first. So, you know, one of the things that you may do, you just calcium hydroxide, calcium hydroxide, calcium hydroxide. You keep rinsing it, and it works out. So, see right here, 2 years later, pretty much 2 years later, and we see healing of the crown. And again, this is another patient that came in. If they fell outside, and so we had to give them. They fell outside, but their tetanus was up to date, so we didn't have to worry about giving a booster. But as you can see here, for the purposes of splinting, those were the 2 teeth in questions. Actually, the 3 teeth in questions. So we went 2 distal of each. Okay. So when you splint, flexible splints. So you want a flexible splint, like the monofilament splint, a flexible splint, like a stainless steel splint, you know, the lighter one, the one that are 0.01 by 0.025 or 0.018 round, you know, the thinner, lighter ones. And again, for these parents, they didn't want to suture anything, so we didn't. You don't want to the inside, so you don't want to do anything. If they say no, you don't do it. So unless it's life-threatening. But the outside we did. Look, healed well. So the oral mucosa heals pretty well. And this is my another patient that had a combination of many injuries happening. Again, it was outside. All immunization was up to date. You can read the detail. Pretty much they went to a plastic surgeon who said that the surgery had to be done through the nose. So the plastic surgeon suggested that a surgery had to be done through the nose, put the kid to sleep on the GA, get the surgery, go through the nose to fetch after the teeth. And I said no. And we didn't have to do GA. We did conscious sedation, and we went and fetched the tooth. And this one will come after our big topic that you need to know, and it's important. Remember it on when you see something like this. When do I let it re-erupt versus do I go in and just put braces, have it come down with braces, or do I go in surgically and reposition? And again, you splint 2 on each side. As you can see, we reposition surgically. I will tell you why. So if the patient, it was an incomplete root formation, you want to allow for reposition, then ortho later, if it's less than 7 millimeter. However, if it's if the roots are completed, okay, there are different scenarios. Less than 3 millimeter, you can let it re-erupt on its own. But if there's no movement after 2 to 4 weeks, you surgically reposition or orthodontically. However, if it's between 3 to 7 millimeter, you reposition surgically or orthodontically. If it's more than 7, like our friends here, that was clearly more than 7, then we had to do it surgically. Okay, bad outcome, usually ankylosis. And then this is just, you can read it, it's where to store it. If you get a call from the parents, you just tell them, you put it in milk or inside their mouth, of the kid's mouth if they're old enough and they won't swallow it. Parents can put it inside their mouth. Never put it in water, never water. Okay. And this is just treatment of Evol's teeth with closed apex. If it's a closed apex, you can, if it's less than 60 minutes, you reimplant, and then after like the 1 to 2 weeks follow-up, you start a root canal. If it's more than 60 minutes, the chances of ankylosis increases, replacement resorption. So, so you want to soak it in sodium fluoride to slow that down. With the open apex, it's different. If it's less than 60 minutes, you want to soak it in antibiotics so that it will, disinfect the area and allow for root continuation. And if it's more than 60 minutes, now you're worrying about replacement resorption. So you soak it with fluoride. Again, you soak teeth in doxycycline to decrease bacteria in the pulp lumen. So if you replant the teeth, you want to follow up, and you just look at the good versus bad outcomes. And for anything, soft diet, let's say a primary tooth with concussion, primary tooth, palliative treatment, soft diet, pain medication as needed. And again, this is avulsion, but within the teeth, within the mouth. Okay. Oh, and then this is another patient. They came in, they had number 9 avulsed. We reimplanted it. It was open apex. So sucked it in antibiotics, reimplanted and splinted. And they came back at the follow-up. There was an abscess. So in that term, we start revascularization. So regeneration endodontics. So you use it, it includes partial pulpotomy, apexogenesis, revascularization. It's a necrotic immature permanent tooth. That's when revascularization is indicated. And partial pulpotomy, again, the important things about this is removing the inflamed pulp and covering it up with a good seal. That way it doesn't, there's no leakage. Okay. Okay. Indication for revascularization. So a tooth is not suitable for root canal, and then you attempted apexogenesis, apexification, or partial pulpotomy, but poor prognosis. And again, your tooth has to have a 1.1 millimeter open apex, the mesiodistal. Okay, this is just goes through the steps of revascularization. Okay. I want to get to primary teeth. Okay, primary teeth. So with primary teeth, commonly laxation of maxillary primary incisors are common. Pick age is 2 to 4. They start crawling, they start walking. Color change, again, doesn't mean extraction. You just want to watch it until you see, the pulps are necrotic, abscess, swelling, bleeding, then you extract. And you also want to discuss, with parents, the permanent saxidine. What's going to happen to them? They could be arrest of the development or delay eruption, severe malformation, enamel hyperplasia, hypomineralization, enamel defects, and root dilaceration. All that could happen. Avulsion, simply put, you do not replant avulsed primary teeth. Don't do it. Other times that you don't replant any teeth is when they're immunocompromised, and control diabetes. So pretty much any medical disease that will prevent them from fighting the disease, the infection. Concussion, as I said, if it's not impinging into the permanent saxidinium, palliative treatment, soft diet, Tylenol Motrin as needed for pain, active monitoring, and then follow-up appointments. Extrusion laxation, this patient didn't seek medical condition. They had an extrusion laxation injury, and then they came in for a recall. I saw the tooth, the color changed. It was brown, but you don't just, extract because of the color change. But however, I did notice the, you know, I did notice the abscess here, and as you can see it here. So at that point, you tell the parents that, this infection may actually affect the permanent accidentals as well. And also let them know that the trauma that they had 4 weeks ago, that they did not seek medical or dental care at the time of the trauma, could result in all those other things, enamel hypomineralization, hypocalcification, root ulceration, if it's in the back of the permanent teeth. At this point, we extracted E and F in this point because F was also looking kind of funky. And, you can see some type of resorption. At that point, we gave anticipatory guidance and the sequelae of trauma and the importance of bringing them in and now waiting. Okay. Lateral relaxation, with that, the tooth is displaced parallelly, usually common. It's going to go palatal. You see the tooth looks like it's moving out or moving in. So most common is it's going to be looking like it's moving in. So it's displaced parallelly, which means the roots are displaced away from the saxidinium bud, which is good. You're protecting it. However, if it looks like it's displaced towards you labially, so the root is probably impinging on the permanent. So at that point, you definitely want to take it out. But if it's not impinging on the permanent, if there's no occlusal interference, allow for spontaneous reposition. However, for severe occlusion interference / displacement, enable to reposition. If you cannot reposition, if the tooth is close to exfoliation anyways, or if it's displaced into the permanent tooth bud, then you extract. Again, with every trauma, follow-up is important. Again, this is another patient that had a subluxation case. Immunization up to date. There was no bony fracture, but as you can see, photograph, you can describe this as much as you can. However, picture is important. I didn't see all this healing. As you can see, they are at the same healing stage. I don't see anything such as, oh, there's a scar here, there's a scar, but a new injury. But all the injury in the face, they were at the same healing timing. They weren't a different healing process. So just to rule out child abuse. And then also, one thing I haven't talked about, you also want to, your behavior management, how you're going to manage that. I said earlier, if, primary tooth with an enamel crown fracture, if the kid is not cooperative, leave it alone. If they are, you do it. In most cases, this kid was very anxious, not very cooperative, and unfortunately, the tooth had to be exfoliated because it was very, very loose. So we used nitrous. That's the pen. And intrusion injury, pretty much pushed in. Again, if it's displaced towards the developing tooth, you extract. But if not, you let it erupt spontaneously. It's different with permanent. Permanent, you have to look at how many millimeters it intruded. Less than 3, you let it go by itself. Between 3 and 7, you can either do surgical or orthodontically. But if it's more than 7 millimeter, it's shoved in there, then you have to do it surgically. That's permanent. Intrusion in primary teeth, even if it's really deep in there, as long as it's not near the permanent tooth, you can let it be. Enamel dentin fracture, and complicated fracture enamel or enamel and dentin fracture. You can just move sharp edges, or if possible, seal the involved dentin. Again, I say if possible, if behavior allows, you seal it. If the child is not cooperative, you don't do anything. Okay. And then crown fracture, pulp exposure, complicated fracture of ENF without pulp exposure, no signs of alveolar bone fracture. Behavior was good. We sealed exposed dentin with GI. We didn't really build it up, we just sealed it. And that's my references. Again, I'm gonna go back to this slide, which is important to just summarize what you need to know. Again, when you're studying, I would suggest either redrawing this, making it one for permanent and primary, and what you're gonna do in each scenario, because primary teeth is different than permanent teeth. In primary teeth, if you have a crown fracture, you don't necessarily have to build it back up based on behavior, because that will detect that. Concussion, again, it's the same with primary and permanent. Concussion, you just leave it alone. It's soft diet. And then subluxation, again, primary teeth, you leave it alone. Intrusion, you leave it alone with primary as long as it's not impeding into the permanent. With permanent teeth, subluxation and intrusion, as I say, with intrusion, you have to see how many millimeter it was intruded. So you treat that way, and you split. And when you split, you want to split with a flexible split. And with that flexible split, again, whatever tooth of interest you want to split, you want to go 2 teeth to the left and right outface. So distal and mesial of the tooth in interest. If it's 2 teeth that needs to be split, then you go 2 on each side of them. Okay. And again, as I said, for splinting, about 2 to 4 weeks. But if a permanent tooth that has a crown fracture, a root fracture, excuse me, usually splinting will be longer. And again, avulsion, you do not reimplant the tooth with primary. With permanent, you do, but then you have to look at open versus closed apices. And again, you always want to rule out child abuse. And when you look at your medical history, you go over, what patients will benefit from reimplantation and what medical conditions that will prevent me from, doing what I need to do, and look at the behavior and rule out child abuse. As I said, I keep repeating that because it's very important, and rule out any closed head injury, cranial nerve involvement, something as easy as if the patient doesn't respond to pupil-like response, the pupil is not constricting when you shine the light, then you say, oh, cranial nerve 3. So I hope you learned something in regard to pediatric orofacial trauma. And again, if you have any question, I'm gonna type in my email address at the very end here. You can shoot me an email for any question. Okay, if you have any questions, just email me directly related to this topic or any other topic, any other topics that you need to know for the, pediatric side and the exam. Thank you. Bye-bye.